Okay, friends, I think we're going to get started here in just another minute. So everyone, please just find your seats. I want to start. I want to start with just an acknowledgement and a thanks to Jamie and to Heidi for doing such an amazing job over the last 2 days. So I wanted to be the first to thank you guys for putting this all together. And then we have an opportunity right now to talk a little bit about treatment. So how this is going to go is we're going to do a really quick introduction to treatment, a 101 course, and then we're going to transition it to kind of a facilitated panel where I'll be asking some questions of kind of our two titans of treatment with both Dr. Blum and then Dr. Jackman. And then afterwards, we'll have an opportunity at the very end for you to ask your own questions. Okay? So let's go ahead. In treatment 101, is I think the reason why we're all here is because we need more treatment. We know that substance use disorders are extremely, extremely prevalent, whether it's to opioids, to alcohol, to nicotine, et cetera, right? And the estimate is 1 in 10 people have an SUD, and it's a little bit different men versus women. And we also know that there's evidence-based approaches that we can apply. That's what the last few days has been talking about, that there's a ton of evidence in prevention, that we can talk about harm reduction and reducing dangerous usage or negative health outcomes. And we know that we can effectively treat substance use disorders. And of all the substance use disorders, guess what is perhaps the most treatable? Opioid use disorder is the one that we have the most medications for. And of course, once we get people into treatment, we can get them into long-term recovery. This is possible. This is something that we can and should be doing much more often. So what is treatment? Oftentimes we talk about MAT, which has become a term that I think is very frequently used, but now is a term that we're transitioning away from, to more medication for opioid use disorder, which is much more specific. Right? And really, there's 3 different medications that we use. Again, this is 101 class, so it's buprenorphine, it's naltrexone, and it's methadone. There's different regulations to each of those, so the 2 that we can use pretty much everywhere in primary care are naltrexone and buprenorphine. And of course, I'll include naloxone here as, again, another medication that's not really qualified as MAT in most cases, but again, is part of that continuum of care that we can give in a medication that we can use to really reduce harm. And here's the big thing. Most people view this as very black and white, that people are in treatment or that people are still using. And it's really not that. There's a tremendous continuum, and a lot of people who are in treatment may continue to use drugs occasionally or frequently. But as long as that treatment is keeping them safer, keeping them healthier, then that treatment actually does have a tremendous benefit to that patient, especially if they're able to start reestablishing their life. So there's a long path to treatment that is often winding. Okay? And then, of course, the thing that's most exciting about treatment is it's perhaps amongst the most evidence-based beneficial thing that we do in medicine. This beats the crap out of asthma. Charlie mentioned diabetes treatment sometimes. We've mentioned MIs and aspirin, but this really does have perhaps some of the greatest mortality benefits of anything we do in medicine. So juxtaposed against that, where we can decrease mortality by greater than 2 times decrease in mortality, and the fact that there's still a treatment gap of between 70 to 90%, depending on the community that you're in, think of how we failed those patients. Think about how much better we could be doing. And I think that's one of the most exciting things about all that we've talked about today. So other things is harm reduction is also a part of treatment. People who come to probably any of our clinics get harm reduction alongside buprenorphine or other medications. And when you look at it too, and this is something that Josh I know is passionate about mentioning, is naloxone is very cost effective. It's around $430 incremental cost to effectiveness ratio. But your mortality benefit from naloxone for people who are still actively using is actually pretty small. So I want to acknowledge that. And I'm very, very passionate about naloxone. But when you talk about naloxone versus MAT and what gives you the better mortality benefit, it's MAT every single time. So we really need to get more people into treatment. We need to destigmatize treatment so more people get these vital aspects. And right now, treatment is more important than ever. More important than it's ever been, because we're in the midst of the fentanyl crisis. We're in the midst of a time when drug use in our populations is more dangerous than it has ever been before. Now, fentanyl does a few things. One, is more deadly, and we know that. There's 2 times the amount of overdose deaths that you see with heroin. And the other thing that it does that you'll actually get maybe a little bit of flavor of today is fentanyl makes treatment more difficult. It's more difficult to put people on buprenorphine when they're on fentanyl. It's more difficult to get them to naltrexone. So we've really used a little bit more methadone in these times, which is difficult because also with different regulations, our ability to expand methadone treatment is sometimes handicapped. So there's some innovative things that we're doing across the state for that. So again, just a brief 101. Now you're going to hear me shut up, and I'm actually going to let you pick the brains of 2 much more intelligent clinicians, Dr. Blum and Dr. Jackman. And I'll transition to sitting down here. But I would ask, just a very basic question again, and this is something that we hear so many times, is, Doc, aren't you just trading one addiction for another? Methadone is an opioid, buprenorphine is an opioid, both of these can be abused. So Josh, are we just trading one addiction for another?
Well, this is it's like a greatest hits of like stigma and shame, right? It's one of those zombie ideas that never dies. This is a question that was asked to Vincent Dole, basically the inventor of methadone for opioid use disorder, literally 60 years ago, certainly more than 50 years now. And it really isn't. Obviously, there is, as you know, 11 criteria in the DSM for opioid use disorder. Most of us think along the lines of the 4 C's. Is there compulsive use, or is there craving? Is there loss of control? Are there consequences to use? And when people are being prescribed or dispensed methadone or buprenorphine or naltrexone, all those C's go away. People don't have compulsive use. They no longer are chasing that high. They're no longer having consequences. And when it's a prescribed medicine, we don't use the criteria of tolerance and withdrawal. So people meet absolutely 0 criteria for addiction when they're on treatment. I think the hard thing is that where this has been the hardest to overcome has sometimes been in the treatment community itself, particularly in places like residences that were sober-based residencies that didn't accept people to be on treatment. And so I think this is a myth that's time has come to be put to rest finally, but as we know with zombies, they tend to keep coming back, so we'll see. But I think at least in the treatment, the fact that now in recovery communities and in places like jails and others, we're actually finally starting to see traction in people accepting OAT or MAT.
So y'all's job is to dispel that when you're asked that.
Oh, good.
Okay.
It's changed from a negative connotation that was oftentimes still bantered about to something that's really positive. And I think both of you, as leading addiction providers, really have some great stories about people who have gone through their addiction and now in recovery. And I just wanted to invite you to possibly share one of those stories, or a person that really you think illustrates the benefits of treatment. We'll start with let's start with
me. Okay. Well, I'll give you a story of 2 different people who I met in the same month in Grand Junction. This was at the beginning of starting an outpatient clinic, so something many of you may be facing if you don't have a large number of treatment providers or the organizations to facilitate that treatment. But I met them at the same time. One was pregnant. I met her on the obstetric floor. She was in her 3rd trimester and was in opioid withdrawal. The reason I saw her is because she was using opioids, but they were concerned that they were going to have to induce her for preeclampsia and deliver the baby early. And I was able to help stop that because she wasn't having preeclampsia, she was just an opioid withdrawal. And we started her on treatment, and all of those symptoms went away, and she was able to transition into outpatient treatment and do well. This was 4+ years ago. She was reunited with her child in less than a year. She's actually in the process of tapering off of her buprenorphine at this point right now because of so many other things that have changed in her life. She has a job, she has a house, she's running her own business actually. Things are going very well for her. The other gentleman that I met the same week, he started on to buprenorphine, and he was involved in the legal system for a number of issues that took place at that point in Grand Junction, including concern for dealing substances that he had been involved in. And he started on to buprenorphine, and life got immediately better for him in the sense that he wasn't in withdrawal. He was able to think more clearly, was able to engage with a therapist in our office, as well as engage with his legal counsel. And through the process over the past 4 years, due to the fact that COVID happened and things were delayed, he's been able to show over those 4 years of being on buprenorphine therapy how stable his life has become, and was able to work through the system and not end up in prison for a prolonged period of time, though he remains in Department of Corrections programs. He is not in a place where he is comfortable, nor are we as his treatment providers, with bringing him off of the medication because of other situations that are going on in his life. But his life is so much better because it's on treatment. He has not had a significant number of relapses or overdoses or other situations he was facing. He's been able to help care for his new daughter. His life is much better. But unlike my other patient, he is in no place, because of his other situations in life and his other mental health conditions, in a place to come off of the medicine. And so just to kind of juxtapose the reality that this treatment can be successful for people and look different.
Josh?
I guess I don't think I want to talk about a specific patient. We all have those stories, but I want to talk about just the pattern of seeing someone whose life is literally shattered, and maybe them picking up those pieces and maybe making a new picture or a new window that maybe is a different picture, a different window. It may be a little bit of a diminished window, but it still shines light nonetheless. And that ability to pick up and rebuild out of that, like the recovery cards, it is seeing people do that becomes, to use a bad phrase, I guess, addicting to me. When I don't know who's going to have that experience, but even if it's 1 out of 4 or 1 out of 10 people, it is so incredibly deeply meaningful to me as a provider, and to the person, of course, experiencing the recovery, that is just something you want to pass on and see so many other people experience. And we fail a lot in medicine. Everybody knows that. Anybody who practices knows we fail spectacularly most of the time when we treat diseases. And so to be successful 1 out of, let's say, 4 times, 1 out of 10 times, but not just successful, see someone literally pick up their life and generate an entirely new, rich existence with loving relationships and work and a home and other things that keep them going and a reason to live and give back to others is profoundly meaningful.
Yeah,
we see it. We get to see it every day. We're so lucky to do what we do.
Yeah, it's miraculous, which is sometimes the irony in the fact that it's so rare, is because you get so much tremendous benefit, and the stigma that oftentimes treatment providers will have is, well, I never want to deal with these patients, right? There's a lot of stigma by providers for them, but then you start actually doing the work and you think, wow, this is some of the most gratifying work I've ever done, and that's at least been my experience as well. Any downsides to treatment?
I mean, other than there's not enough of it. I think the reality of the downsides to treatment are, one, barriers and being able to access that treatment. So there's been a big effort to increase the number of providers who are prescribing things like buprenorphine, but we know that a small percentage of them actually practice and do that because of uncertainty. And so in rural communities like those I work with, that can be a huge barrier. So just being able to access effective treatment. I think the other part that is the downside to that, the other side of that coin, is once you access treatment, particularly if you're on methadone or buprenorphine, to Josh's point, there are no signs, you don't meet any criteria for addiction while you're on these treatments, but with those two, methadone and buprenorphine, you do become dependent on them, in that if you don't have them, you will go through withdrawal. And so I think one of the things that you have to be aware of when you're making a big push for allowing people to access treatment is they need to be able to continue to access treatment. And so if there's a big push to get people onto treatment, you also have to have the ability to continue that treatment, because there is definitely risk, including overdose, if people are started on this medicine and don't have access to that. And I think, as we've identified in prior discussions, one of the areas that is abundantly apparent is the individuals who are either going into jail or leaving jail in their ability to continue to access these medications. And I think in the past 2 years, we've seen our state do phenomenal work there, and it is not nearly the barrier it was 3 years ago. But I think those are some of the things we have to be mindful of as downsides to treatment, is being able to make sure access continues.
So one of the things I wanted to bring up, because I think this is a state of big confusion for those, is what, there's so many different aspects of treatment, and there's so many acronyms, whether it's OBOT, which is office-based, whether it's OTP, which of course is more tightly regulated, whether it's inpatient versus outpatient versus IOP. Can you kind of give us a quick maybe rundown, Josh, of what that landscape is, especially for all of you who might be looking, where should we invest? Can you give us a quick rundown of that?
It's an alphabet soup, right? I guess just starting with OTP and OMAT, opioid treatment program, or oral methadone treatment, or methadone agonist treatment, is the term for a methadone clinic, OTP or OMAT. And that actually dovetails nicely into a downside of treatment. If you are in an OTP, the OTP is a very restrictive place. Methadone is regulated by rules that were put in place over 40 years ago, and is overseen by about 20 pages of SAMHSA guidelines, about 160 pages of state guidelines. There's DEA guidelines, there's Medicaid guidelines about how you bill for them, and Joint Commission as well. So if you're in an OTP like I am, you are held to standards by at least 5 different masters, regulatory masters. And so if you're a patient in that, it's impossible to completely destigmatize something that has so many rules that if you violate one of those rules, you get knocked down. It's like a game of chutes and ladders a little bit. You take a lot of time going up the ladders, and then something happens and you drop down the chute. So the regulations can make you feel stigmatized and make you feel like a child. Literally, I have a 78-year-old woman who said, "I can't believe I'm being dropped because of a violation of a missed urine test," but because this woman has been on methadone for about 40 years, 30 years, and she's just, she's incredulous that this is happening. But anyway, OTP and OMAT mean methadone clinic. OBOT, office-based opioid therapy, means typically buprenorphine-based treatment, or maybe naltrexone-based treatment. And maybe stop there from an alphabet soup standpoint, because I think everybody's eyes have already glazed over enough with probably the number of acronyms they've heard over the last 2 days. But if you know that, at least that's a good start.
How about that continuum, though? Because I think so many people think, oh, well, they're getting opioid treatment, they need to go to detox, or they need to go to rehab, because that's so oftentimes what families come in expecting. So where does that lie in the continuum?
So an OTP or an OBOT both are considered outpatient treatment. They're actually level 1 in the ASAM continuum of care. You guys heard, if you were here yesterday, about the ASAM levels of care, and there's levels 1 through 4. And so OTP and OMAT are both OBOT are both outpatient levels of care. A lot of times and this actually speaks to the opaqueness of this system, where you not only have these levels of care, but then you have an entire book that actually tells you how to apply those levels of care. And then when you're talking about getting people into treatment programs, every treatment program has its own application process and different rules. So this is not a user-friendly process. To talk about how the medical establishment is failing patients, look no further than trying to get somebody into care for the first time. It's much easier to stay in care once you're in care. But so level 1 is outpatient. Level 2 is considered intensive outpatient, so that actually has a specific meaning in terms of the number of hours of counseling that you're going to get per week if you're in an intensive outpatient program. Number 3 is level 3, and there's different gradations in these levels, is residential treatment, and that can be from low to high intensity treatment. And that's like when people think of rehab, they usually are thinking of a level 3 kind of level of care. And then level 4, which is actually like hospitalized, medically managed care. It's the highest level of intensity. The problem is when people think, I have a loved one who's in need, this person needs rehab, a lot of times they're not thinking along those ASAM criteria and those axes of care, including like what is their risk of relapse, what's their biomedical conditions or their psychiatric conditions. But I think of all the things, what I would want you to take away is simply that the goal is to get people to the lowest level of care that's going to be effective for them. So if someone's never failed outpatient treatment, because they've never tried outpatient treatment. Maybe they need rehab, maybe they don't. Maybe they simply need to be connected to outpatient treatment and they're going to do great. So I think a lot of times and this actually was shown yesterday in the information from the Coast Law program, you actually have to have an access point for providers actually to refer patients so they can actually better clarify what the correct level of care is for their patients. This is complicated stuff. And so not only do you need that access for the patients, you actually need it even for providers because most people can't really manage this on their own. And so Coast Law had a provider line. We at Denver Health have like a special provider referral system where you can talk to an addiction expert even as a clinician so you can better understand what the right level of care is for your patient.
And let's talk about a little bit of the difference between what treatment looks like in an urban environment and a rural environment. And because I think that there's different challenges, and we've alluded to those several times. So, we have, two of, I think, the foremost experts in running a rural OTP/treatment program, and then urban, and then running a rural treatment program. So why don't we start off with Ryan talking about what this looks like in the rural environment?
Those of you who are here from our urban counties, you know what it's like to live in an urban county, and you know that anything that gets done in an urban county is done by the people who care about what's going on in that county. It's a lot of collaboration. It's very rare that you're going to see a large entity come in and provide you these resources. And if that large entity comes in, it's probably a pretty good chance that they won't be trusted and they will not be connected very well. And so when you're providing treatment in a rural area, and I think many of these things probably translate in a little bit of a different way between urban and rural, but you really need to be able to, one, provide evidence-based treatment, which means we need to be able to be providing treatment that is going to give us the results. A lot of the communities that I work in, they're trying their best, but may have not had access or had training in some of these areas. And so expanding the ability to provide evidence-based treatment is very important. Two, you really need to be able to destigmatize treatment while also accepting that you have to work within the realm of stigma. And so the way that looks where I practice is we have a lot of community events where we're talking with community leaders and getting them to understand. And the best way to do that in a rural community is the best way to do it anywhere, and that's with a narrative and getting people who have recovered and want to represent that recovery and talk about that and get the story going. Because when you know the person who's in recovery and they're from your community, it breaks down stigma more quickly. But the reality is there is stigma, and you may not want people to know that you're in treatment, and so being able to provide some level of anonymity at the beginning. And so the way we do that in our clinic in Mesa County, which is not rural, but we take care of plenty of people that are rural, is we have no sign on our clinic. And our clinic is co-located with a primary care office. So if you're coming to see us, you could be coming to see a primary care doctor. No one knows what they're coming there for. And so that has been very helpful in increasing access. And then beyond that, just the fact that you need to be able to, there's a continuum of treatment that we highlighted. When you're seeing a doctor or you're seeing a physician, that's 20 minutes, 30 minutes, an hour maybe of your whole week. And addiction isn't just present during that appointment. You're living with it all the time. And so being able to have resources, recovery-specific resources available in your community that are run by your rural community is so helpful. The thing that has made the biggest difference in Mesa County over the past 5 years that I've been practicing, aside, that I guess I would say number two, because medication-assisted treatment has made the largest difference in being able to keep our overdose numbers low and increase the number of treatment. But the second thing, in my opinion, has been the just outburst of effort by the recovery community in Mesa County to make activities available to those who are in recovery, because it's really a then what situation. Okay, I'm on my medication, but I have to go home to the same situation or to the same stressors and the same triggers. Now I'm starting to change my life. I'm going to art night with Pier 180, or I am going to this meeting, or I'm going to this recovery rally with people who are sober and who are celebrating that recovery out loud and realizing that there are way more people in Mesa County who are in recovery than there are in active addiction. And that's powerful and has made that transition point so much easier for our patients. And so partnering becomes really important.
I think a substantial difference. Really, there's more similarities than there are differences in the rural and urban treatment environments. But I think one thing that tends to get highlighted is how many more resources we have in the urban environment. I would simply push back by saying, well, we have more resources, but we have way more demand. When you actually look at just the numbers of people with opioid use disorder who are untreated, the majority of untreated individuals are in that urban setting. So even though, yes, we have more resources, we certainly have more residential facilities and things like that. Compared to the number of people who need that resource, it's still a drop in the bucket. So I think we're still competing for a very, very limited number of resources and a very incomplete continuum of care. And so in that sense, we're actually very similar to the rural environment. I think a big thing I'd highlight just in recent years is simply income inequality and people who are unhoused. And that's maybe something that might be a little bit worse in the urban environment. You know, if you being unhoused isn't usually, or substances, I should say, don't usually cause someone to become unhoused. But once you're unhoused, substances contribute to someone not being able to get out of that cycle, literally that reinforcing kind of death spiral. And so the idea of like trying to find someone a roof over their head when rent for a studio goes for $1,500 a month at the cheapest is such a huge lift. Moreover, when you do find housing for those individuals, it's overwhelmingly likely to be somewhere where lots of people are using substances. So maintaining recovery and just the sheer number of exposures to substances in the Front Range area, you know, where it's not just one part of town, it's literally every part of town. And access to these drugs is so ubiquitous that I think maintaining recovery, especially in the setting of being unhoused, is extraordinarily difficult. The other piece, though, is, at least because we do have these additional resources, is coordinating between them. It's challenging, but it's really rewarding when you do have a relationship. Denver Health has a working relationship with Sobriety House, which is a residential level 3.1 and 3.5 treatment facility. And so we have the ability to connect people into care because we have a working relationship where we even share some electronic medical record information with them. And so that feels really good when you do make those connections. But it's, again, there's overwhelming need.
Yeah. So, you know, there's a lot of people here who are looking at this, and maybe you're bought into treatment. You're thinking, wow, we need more of this in my community. Maybe you're in a rural community there that treatment's very, very hard to access, or treatment is non-existent. So the question to both of you who've actually stood up really great programs is, where do you start? How do you start building a treatment program if your community doesn't have one? Where do you invest?
I mean, you really have to invest. To the continuum discussion, you really need to invest in the area of 1 and 2 before you invest in 3 and 4, in my opinion, because inpatient treatment, so 1 and 2 is all outpatient-based treatment versus 3 that would be residential and 4 being you're going to the hospital. The reason for that is residential treatment is a period of days, weeks, maybe months, with the way insurance is working currently. And so that's very intensive, it's helpful, and some people need that. But after that, then what? And if you don't have your framework set up to be able to provide outpatient treatment and help reinforce those lessons that those individuals are learning in residential treatment, they are not leaving residential treatment, quote unquote, cured or incredibly stable, because it's not real life. And they're going to go back into the same place they were before, and they're going to need help putting those new coping skills, taking their medications even maybe as a base level of that, where residential was making sure they were taking them. They've got to do that on their own now. And so if you're going to invest, you're going to get more bang for your buck investing in outpatient programs, where, and this is to the point, the workforce deficit is going to be an issue, but building up programs that can provide intensive therapy, intensive contact points, medication-assisted treatment, because even at a baseline, if they're just getting medication-assisted treatment or medication for opioid use disorder, their level of stability is so much better than before. And so that gives you time. That's what you're looking for, is you're buying time. These medicines, these interventions are pause buttons to give the brain time to heal, but also give life time to heal so that they can have that contributing support in their lives.
I think the other point about, yeah, exactly what you just said is that there's just so many more people who need a lower level of intervention. Like, from a purely utilitarian standpoint, you get the most bang for your buck at the lower levels, just like we were talking about with prevention earlier. Yes, if in ideal world we would have started this work, this conference would have first been held 20 years ago, and then the kids using today would have been not using, and we wouldn't be here. So, but similarly, lower levels of treatment impact and have the ability to help a lot larger numbers. So rather than spending all the money on the tip of the iceberg, it's really getting to the fundamental, the large numbers who need maybe a little bit less.
And I'm going to add my own thoughts to this. Is it starts with people. I've stood up 2 rural treatment programs, and it's really like, oh, let's get one of our docs to get their X waiver and actually accept these people, who then we start in the ER. It's not really rocket science to set up a lower, an outpatient level of care that at least starts meeting the demands of some people in your community. It does take some training and stuff, but it's actually something that's really rather easy to implement once you actually start with it. So what are some thoughts that maybe both of you have, or lessons learned about setting up best treatment systems? We've kind of alluded to it, but kind of your best practices, if you will. Maybe for people who have a treatment system that exists, but maybe is not optimized or maybe harder to access. So what does good treatment look like to you?
So I'm going to start with a little bit of a caveat, which is I'm really blessed or lucky enough to work at Denver Health, which is its own vertically integrated system. It's basically like the entire Coast Law hub and spoke model in a single healthcare system. And so that we had really willing and motivated partners in the form of our Center of Addiction Medicine, run by Brooke Bender, who's sitting over on the left side of the room, and John Mills. Have to give a shout out to my people, because what we have is, you always find the early adopters, you find the people who are the doers and the people who want to make a difference. And we're lucky enough there, where everybody just, instead of saying, no, that can't be done, they say, well, how can we make this better? So from our standpoint, is anybody else hearing that? Okay, just want to make sure. Good. like person from yesterday, I'm not hallucinating. Okay, thank you. That we talked about some of the limitations of treatment, right? The system is totally opaque. There's a huge barrier to getting in. So best practice is you make it transparent. You have one way to that's easy for people to get in, but you also have multiple nodes. In our system, you can enter from the inpatient ward and wind up being admitted for something else, but if you undergo opioid withdrawal, you're going to get titrated onto methadone or buprenorphine. Through our ED, through our jails, where we do the medical care at Denver City and County jails, you can get started on treatment in the jails. You can walk into our outpatient addiction. You can walk into primary care. Any of those places serve as a node of entry, and once you're in the entire system, and you can move throughout the system and even be transferred, but without doing another intake. So it has to be easy with multiple portals for entry, has to be transparent. Everybody has to communicate with everyone else. We know there are limitations based on some federal regulations, but you really need your whole treatment continuum communicating. And then it needs to be trauma-informed. We talk about stigma and shame, but you're only as great as your worst employee. So it only takes one person who's like mean to a drug, some person who uses drugs, or says, you don't deserve anesthesia, before we IND this abscess, and that's undone all the good work done by the countless people who came before that to actually make the person feel welcome and at home. And then finally, you need to collect data, right? Good treatment looks like offering all the medications, but then also collecting your results from that. And what we do is we look at anybody who's had any touch in our system, and then following that person over time and find out who wound up getting inducted on medicines, who returned for care, who's retained at 60 days, who's returned at 90 days, who's retained at a year. Notice nowhere in there are we checking how many people had negative urine toxicology screens. We don't really care about that as an outcome measure. We want to know who's alive and who's in care and who's engaged and retained. That to us is a measure of success, to borrow again from the harm reduction approach. That's what we need to know, not how many people tested negative for a substance. That doesn't tell you about the person's life.
I really have nothing to add to that. That was exceptional. I think that for those of us who don't work in a fully vertically integrated system, that's the dream to which that we continue to work towards. And it's going to take time, and it can be an uphill battle, particularly where you're using multiple systems. I think there are many ways to contextualize addiction, and here we're talking about it in the disease model. And I think where I've gotten the most headway in having conversations with my colleagues, as far as to your point of you can access this anywhere and then you go to one location, is doctors can prescribe antibiotics wherever you are. And if somebody comes to you with an infection, they don't have to wait to see the infectious disease doctor. They can get started on antibiotics. And it seems silly, but that opens my colleagues' eyes to what we're talking about. You can start the medicine wherever you are and help them right then. Because if you don't, just like an infection, this person could die before they get to the infectious disease doctor. It's silly, but it works.
I actually love that analogy. Let's talk a little bit about, we talked about multiple systems. Let's actually talk about multiple substances, because we know that besides just opioids, we have a very substance-laden society, whether that's with alcohol or out west. Many of us see methamphetamine very, very frequently. So what are the unique challenges possibly to treating people who have polysubstance use disorders?
I mean, just to go back to the disease model, these are two separate diseases. They affect the same organ, which is the brain, but they're two separate processes. And that's another thing that we have to keep in mind, because oftentimes there's this stigma that treatment means 100% sobriety and abstinence. And so if you're not doing that, it's a failure, so we're going to change treatment programs. Well, it's to compare it to two diseases. If you have somebody who has diabetes and they also have high blood pressure, when they continue to eat donuts in the morning and have uncontrolled blood sugars, I don't stop their high blood pressure medicine. So that's how I talk about it with my colleagues, in that, yes, they're using multiple substances. The root cause, be that trauma or other issues in their life, may be the same, just like diabetes, high blood pressure, high cholesterol. They're all interrelated, but they're all separate in their own pathway. So let's treat opioid use disorder for what it is, and let's use medication for opioid use disorder. But if somebody uses methamphetamine, you do not stop their medication for opioid use disorder, because it doesn't treat methamphetamine use disorder. That's a whole nother treatment path that we've got to talk about. And so just being able to acknowledge that these are complex, intertwined conditions that require a range of treatments.
Totally agree with that assessment. I would just say from an outcome standpoint, we know that when someone enters care and they have multiple substances that they're struggling with, they're more likely to fall out of care and maybe less likely to have a great outcome, particularly with methamphetamine, which is clearly associated with research as being more likely to result in somebody falling out of care. Of course, when you compound that with things like someone who's unhoused and they're actually using methamphetamine so they can stay awake in order to not, in order to stay safe overnight, which we definitely see, or that methamphetamine causes psychosis, which makes it really hard for them to stay organized enough to stay on their treatment. You can see how it leads to people falling out of care. It doesn't change our initial approach, though, as Dr. Jackman said, to treating the opioid use disorder. And what you do see when people do well is that when you treat the opioid use disorder, A lot of other things settle out. Maybe their alcohol use doesn't go away, but they might reduce their use. They might be using methamphetamine less frequently. And so you actually often see improvements in the other substances, maybe not complete elimination, but improvement and improvement in function when you have successful stabilization of the one disease, the opioid use disorder, for which we have good treatment.
It's all about keeping them in treatment.
So I want to give time for questions from the audience. So any closing thoughts from either one?
Do you all want to go to med school? So now we'll have a great treatment. You're saying you don't want to go back through med school again?
Can we do that in a microphone? Oh, sorry. We've got people on Zoom.
I'm going to make one comment, which is simply about maybe the silver lining of the pandemic, and we could talk about that for a minute, which is from my world, from the OTP world, and Denise, I see you're nodding too, that SAMHSA gave us a lot more permission to allow things like take-home doses for people. And so the restrictiveness, the incredible restrictiveness of methadone that's based on laws made 40 years ago was relaxed to a point where we actually could start treating people like adults a little bit more, where you didn't have to be in treatment for a year before you could have a week of takeouts. That has been a game changer for us. It's been really good. I hope the genie never gets put back in the bottle. And the access to telehealth is the other big game changer. And, you know, again, we hope that neither of these ever go away. If they do, my goodness, there's going to be a revolt, a total riot of, and not just of the patients, of the providers, because it's been so good for treatment with no increase in the risk of death from the use of the medicines, that I think that's just the one piece I might finish with.
It's a good soap.
I haven't seen this from the clinical side of it, but seeing it from the boots on the ground, up close, personal, in people's lives. What I've seen is if they are on Suboxone, they tend to use more meth than they were. More other drugs increase because they're not getting the high they want. So, but commonly they will put it in their cheek and then sell the Suboxone for heroin. Some have told me they are actually shooting the Suboxone. I don't know if that's possible, but that's what they say they're doing. The getting to the dosing, so originally they were giving like a whole, month's supply of Suboxone. Well, that was just being sold. I mean, it was not being used. But then they started requiring that you have to go to the facility every day to dose, and then that interfered with the ability to have a job. So that was a mess. And, if they don't have a car, then getting to and from dosing at the right time gets very complicated. If they're on methadone, they can still get high on heroin. Detoxing off Suboxone is harder.
Up. I don't even know where to start with all the myths you're bringing up. There's so many good ones we can do this.
Where are you from?
Yes.
Where are you from? What part of Colorado?
Right now I'm living out in Sterling.
Oh, okay. Okay.
Some of this I am getting from the addicts. That's what they're telling me
Okay.
they're doing.
So individuals with substance use disorder, being a condition and knowing that it affects the brain, we all can agree that people with addiction and substance use disorders act differently and may act in a way that may go against their best interest. These are symptoms of the condition. And so it is not uncommon when people are starting on medicines to maybe take more because they're used to taking something to not feel or to feel euphoria, to your point. So it is not uncommon for that. If they don't feel that euphoria or that numb feeling, is it uncommon for them to maybe fall out of care for a period of time or to trade their medicine for something they want? These things happen. These are not, from the national data that we are following, the norm. They do occur. So they are things we are aware of, and as clinicians, those are things that we have to account for. At the end of the day, if Suboxone is sold on the street, if you look at the people who are purchasing it and using it, generally speaking, these are individuals who are not wanting to use their opioid of choice. And so this diversion is not the worst thing. On top of that, buprenorphine is a much safer opioid in comparison to things like heroin and fentanyl. In order to overdose on buprenorphine, you really have to combine it with large amounts of other sedatives. And so people aren't going to die if this happens from a public health standpoint. So yes, does it happen? Yes, but it's not the norm. I'll let Josh address some of the euphoria and overdose risks. Or
Just very quickly, and I'm happy to see you after class if we want to talk further about these. But so of course I get it. You're the messenger. I'm not going to sling arrows. But that Suboxone is actually the most diverted opioid in the country. It is diverted tremendously, and as Dr. Jackman said, when it's diverted and it's used mainly to treat withdrawal symptoms. And in fact, in France, where it was incredibly highly diverted, when they removed the requirement that you had to have a special waiver to prescribe it, and everybody could prescribe Suboxone, all that diversion went away. Because it turns out it really was being used by people who are in withdrawal who wanted to treat withdrawal symptoms. Is it possible to get euphoria from buprenorphine? Yeah, it's not great. Most people don't like it. It's not preferred by most drug users, but it's possible. It's a little bit of a risk we take. And as Ryan said, there are some people who they're engaging in the old behaviors on their way towards recovery. There's no evidence for some of the other things you mentioned about methadone or buprenorphine being harder or easier to taper off of than any other opioid. There's really just, it's a little bit of a pick your poison aspect there. Some people say it's harder, some people say it's easier, so we don't have a lot of evidence there. Methadone certainly gets used, or traded as a commodity. It's one of the reasons why we actually do urine toxicology tests. One of the most important reasons is not because I want to catch you using other drugs. It's because I want to know that you're taking the medicine that I'm giving you. And so really, that's really what we use it for the most. And it's only when we see people repeatedly without the drug that we're actually prescribing that we would potentially discharge a patient.
I just want to bring one other point, is we have an amount of kind of moral absolutism about this disease that we have with no other disease process, right? So, I have lots of people who have heart attacks who continue to eat bacon double cheeseburgers. I have lots of people with diabetes who are continue to be overweight and don't exercise, right? And there's stigma associated with those conditions, but at the end of the day, I still care for them. I still want them to have their best lives. And I still want to apply the treatments to them that I know the evidence says are the best for them. And with this disease process, those medications, which we acknowledge do have some addictive properties as well, usually make people safer, better, and healthier when we apply them within the treatment algorithm or treatment programs like we're using. So I'd say that really, I'm so glad. By the way, I want to actually thank you for bringing those up, because we need to. It's wonderful to hear, what people have been hearing. And to also have the opportunity to acknowledge those concerns, and then to be able to address them, because at the end of the day, we want to address every single one of those concerns that you or other people in your community might have, so that you're also comfortable with that treatment. Because oftentimes patients come to us with those same concerns, right? Yeah, so we have this conversation probably on a near daily basis about trying to destigmatize. Exactly. So thank you.
Yeah, I'm Allison Gossman from the Practice Innovation Program at the University of Colorado, and I want to let all the communities know that our team is funded by the SOR grant and others to help practices, outpatient organizations, whether they be primary care, which is my primary shtick, but will help any ambulatory care practice, A, get the training, B, train the staff, help them set up policies, procedures, protocols. So we are funded. It will not cost an organization money to learn how to become one of these providers. I agree, we got two of the state's experts right here, but it is a treatment that primary care can learn very quickly. Our goal is to have practices be as comfortable treating opioid use disorder and other substances the way they are diabetes, asthma, cardiovascular disease. It's just another chronic condition. And as a university training program, we know how to train providers and we're funded to do so. So if any of your communities want to enhance access and make it as easy as possible for patients to get it where they seek their normal care, we can help.
Just wanted to say thank you and to reiterate some of the things that you said about the ASAM with level 1 being the probably the first start. Just to remind people that people can get worse. If you start them at a higher level of care, we know that they can get worse. That's evidence-based. And then the other thing is, as a provider, outpatient, we aren't as lucky as Denver Health where you have the full continuum. An area that we struggle that could be an opportunity for the councils is that sometimes not all treatments get along. So when we as methadone providers try to put somebody in a higher level of care for things like benzodiazepine dependence or methamphetamine dependence or alcohol dependence, frequently our patients are turned away or told that they have to get off their medication. So even in the treatment world, we see the stigma, and so we're just asking for your help and your understanding in that our patients need to stay on their medication, just like we talked about the two types of medical conditions.
I have two questions. One is really around terminology, just for my own. When we talk about inpatient and outpatient, is there very strict definitions about what that means? Or the reason for my question is, coming from a rural area, can those lines be blurred? Does it look like inpatient, even though it may be technically more outpatient?
So let me answer that one first. The difference between inpatient and outpatient is whether you're sleeping at the facility, basically, is the simplest way to break it down. There is a world that goes between the two that's called a partial hospitalization, and I would say that that is the service that I see the least in our state. The reality is that those lines aren't blurred, and the reason for that is because you have to have a very specific license to operate at each of these levels, and so you really can't blur. So does that answer your question?
Helpful, thanks. My second question is really about combining a couple of the things that you all are saying and Dr. Stader mentioned about people, that at the end of the day it really comes down to people, and maybe in urban areas it's the people that do the grassroots stuff, and I've seen that too in our areas, where in rural areas, I call it the same 10 people thing. You have the same 10 people that serve on the school board and work on the committees and do the volunteer work. And oftentimes really great programs or services that where the passion of a person die when the person retires, goes away, moves out of the community. Whether it's a vertical system like Denver, or if it's not, if it's disparate programs that work together, as you mentioned, is there one suggestion you would have or that you've seen that from a systems approach we might think harder about, so that when people change, the good programs and services can remain?
I have a thought on that, which is really just piggybacking on what Allison said, which is that if you want sustainability, this has to be part of primary care. That is just seen, that treating addiction is just seen as being part of any primary care practice. And so primary care, you don't collate, it's not even co-locating addiction treatment in primary care. It's the primary care is the addiction treatment. So when because most places, even though there's shortages of everything and everybody in every job description, there's usually a primary care provider somewhere. And so at least if there's somebody there, that's a way to sort of inoculate your community, so to speak, against never having anyone available. And so I just think that part, and that's as my bias as a primary care clinician, is that this is really something that we all do, just like we would all prescribe antibiotics or treat depression, even though we're not psychiatrists. The buck stops with us.
I agree with that as a primary care provider. Not all my colleagues do, but as far as medication for opioid use disorder, that's the way to keep it around. As far as integrating the different levels of care and keeping that going in a rural community, just thinking about our community. I think the way that we've kept that is by just scheduling it, and by that I mean for our collaborative work, it's scheduled into the day. There's an expectation that we're going to work. I probably assume you do this with your inpatient facilities that you work with, that you're going to staff patients or talk with them. With our Mesa County Opioid Response Group, it's just scheduled, and the people are knowing who's going to be invited. So as there's turnover, other people are stepping up, and it often is going to be generationally the same 10 people. But that's how we do it, is just making sure that this is the first day of the week or the first Tuesday of the month. It's always going to be then, and all the providers know so that they can come.
In terms of resiliency, I do think that there's several things to think about. One is outside of primary care, I think also your hospital is a huge potential thing to leverage. And while it's, inpatient versus outpatient, like in my small rural hospital, if I have a person who I can maybe do an induction on, but they need another 24 hours before I'm able to do it, I just admit the person, oftentimes just to myself, right? But I mean, you can actually have some inpatient capabilities if you do have staff or whatever that's trained in your small hospital. You can stabilize people who might be very unstable, right? That's in fact the highest level, right? Level 4. It's they have a doctor that's actually supervising their detox. So you can actually provide some of those services in your small, rural 4 or 5 bed hospitals. You just have to have providers who feel comfortable and then who also feel like this is their responsibility to care for those members of their community. The problem is some of those doctors haven't felt like that's their responsibility. So guess what? You're shit out of luck. Get the hell out of here, right? And that's been the wrong approach that's left people languishing for way too long. And again, if we, even in small places where you're never, every rural hospital is never going to have the fanciest specialist. But this is a really easy disease to care for the most part. This is not rocket science to get people on medication. We just have to demand that our medical system actually does it. We have that expectation. And then in terms of building that longer term resiliency, outside of that expectation, you actually just have to fund it. If your doctor is whining about it and saying they're too damn busy, say, well, what if we give you a stipend to get some education and we'll pay you to get educated? I've seen a lot of doctors stop whining with that, right? So the incentives are still kind of the same for clinicians as they are for almost every other person. If you incentivize it, if you make it an expectation, people do it. And then once you have that as just this is what we do, then it has its own inertia.
Just quickly here, we've kind of touched on this in the last few questions or whatever. I'm from Colorado Springs, and recently there was a bit of controversy within our community. One of the organizations that specifically provides opioid treatment outpatient tried to set up a new clinic in a new part of town. They were going to buy a church in a relatively, they call it a buy and die neighborhood, right? You buy your house there, you never leave. And the neighborhood threw a fit. Totally was like, oh, these services are great. We acknowledge that you need them, but not in my backyard. As people who've actually set these up, and you talked about this a little bit, community engagement, education, things like that, but have you encountered that in your efforts, and how do you get past the NIMBY?
The only way that I've seen to successfully get past that is with a narrative, and it has to be somebody from that community. There's a lot of bias and there's a lot of stigma, and the only way, we continue to make these efforts, we continue to educate, we use the disease model so that people can relate more easily, but in some of these situations, the only way to get that to change is to get somebody from that community to come forward who is a respected member of the community and to talk about it. And that's why I think the efforts we're making and the gains we're making in the state to destigmatize it, like lift the label, it's allowing people who are not stigmatized as what I anticipate is an individual with substance use disorder looks like, and they can say, this is what this has done for me, and that changes everything.
Last question.
last one is really just a comment because in 2 days of drinking from the fire hose, this is the one thing I've actually been able to speak and say something about, is that you mentioned the importance of telehealth. And I can say from the industry that I'm in with my day job, this is not going away. So the accessibility of specialist care, the accessibility of primary care when you're hours away from your primary care physician is not going away, and the infrastructure for that is being built very, very solidly. So I think that will be with us a good long time.
Thank you. I would just say, we realize, sort of the light bulb went off for me. Like, this is a game changer. A lot of us are doing care, and why couldn't we pool our resources a little bit and provide some telehealth for places in the state that don't have the large number of providers that maybe Dr. Jackman and I have, and can we just share those resources throughout the state so that no part of the state is without treatment providers?
And what I would add to that, having now done a lot of telehealth into more rural areas because we're allowed to, as you go back to your communities, if you're coming from a rural area, you're doing your needs assessments, one of the people that you need to involve at the table is your local pharmacist, because your pharmacist needs to understand how this works, why you do it the way you're doing it, and they need some education as well so they're willing to carry the medicine. Because to the point of the downside of medication-assisted treatment is when you can't get it. That has been a barrier in our small communities, is having enough of this on hand.
I'm just going to invite people to read the last 2 slides that we have. We're not going to go through them because we don't want to get off time, but I want to just end by thanking our panelists for sharing your expertise and for what you do in our state.
This is one of those panels that I'll be going back and rewatching. So just a plug that these will all be available